Dr. Abi Sriharan. I'm an assistant professor and a program director at the Institute for Health Policy Management and Evaluation. My research focuses on health systems innovation and wellness, especially around leadership wellness. And during the COVID situation, my team got a research grant from CIHR to look at pandemic stress and burnout among healthcare workers. And today's panel, and we'll discuss some of the early findings, but also bring in some experts from Canada and US to talk about burnout in healthcare workforce. You could use the chat function if you have questions as we progress with the panel. We will start with a short presentation, panel discussion, and then we'll have some time for discussion. And again, to acknowledge my research team, the research was collaborated with Dr. Savitri Ratnapalan from the Hospital for Sick Children, Dr. Doina Lupia from the Ontario Medical Association, and Dr. Andrea Trico from the Unity Health. All of them have UFT affiliation as well. And this research is supported through the Canadian Institute for Health Research Operating Grant, Knowledge Synthesis, COVID-19 in Mental Health and Substance Use. So why are we doing this research? And for those of you who have been tracking healthcare workforce and COVID-19, as of August, Amnesty International has estimated about 7,000 healthcare workers have died around the globe. Most of these deaths are from Mexico, followed by US, UK, Brazil, India, and South Africa. One of the major issues with these numbers too is there's not enough documentation of actual deaths of physicians or other healthcare workers. So this is an estimated number based on what has been reported. From a Canadian perspective, as of July 2020, we had about 21,000 cases of healthcare workers who have been infected with COVID-19 and about 12 deaths. Actually, as of August, the number has gone up to 19 now. And about 20% of the cases in Canada have been healthcare workers. And 80% of this number is actually female healthcare workers. So you can see the impact of COVID. And we have been seeing, again, like I have showed some of these numbers, but the problem is these numbers have not been well documented. And we are talking about these people. These are the faces of healthcare workers who have been impacted by COVID-19, but that's death only. And there's more than death. Like, we are seeing the death numbers, but there's a lot of burnout and psychological impact of COVID-19 that healthcare workers are facing. And we have not been able to document or track these things. I know organizations are starting to look at what can we do, how can we improve that. So our research wanted to explore what are some of the triggers of occupational stress, burnout, and depression faced by women in healthcare, especially when the public health measures were put in place and the schools were shut down. The care responsibilities also fell in on top of the healthcare responsibilities that women in healthcare were facing. We also wanted to understand what are some of the organizational and systems level interventions that could support the well-being of women and healthcare workers during a pandemic. So those were a couple of key focuses of our research, and the grant that we got from CIHR is to do a knowledge synthesis of published literature. And between January and June of 2020, there have been about 3,600 articles published around this topic. So you could see the sheer volume of literature that was coming out. And we were more interested in the research studies. So there were about 76 research publications on this. And most of these studies came from China, Italy, Iran. So as the trend of COVID was moving from China to the West, the research was kind of emerging. Very limited research from US Canadian context when the last search in June. Our current search is being updated right now. So I'm hopeful we'll see more research studies and more understanding on what's happening. But the early results show women, especially younger women with less experience in healthcare, are feeling the burnout. That's more around because they are not prepared to face COVID-19. They didn't have enough training. And there's also a factor of social isolation. If younger women who are single, they feel more burnout. The second group of women who are feeling that burnout is mid-career women who have caregiving responsibilities. Either they have caregiving responsibilities for younger children, or they have caregiving responsibilities for their parents, so that sandwich generation. And then mid-career women who have more than 2 children are the ones who are facing more burnout. Again, these are emerging research from the studies. And then we looked at what are some of the common concerns. And the main thing is around work environment, access to PPE, and the safety around their personal safety, but also the safety of their family. So they come to work with a proper PPE, and then what happens next? And then infection control protocols within the institutions that they work, and whether there's a really well-planned infection control protocol or not. Work hours, long work hours, and lack of sleep. So it's kind of work environment that leads to personal challenges. Professional stigma, and this is more so in the US context and in other countries, is also layoff and income changes because of COVID and clinics being shut down, surgical units being shut down, and then what happens to the income of the healthcare workers. And again, we are talking about healthcare workers broadly, from doctors to anyone who works, like personal support workers and nurses and other healthcare professionals, right? Redeployment, so a lot of people got redeployed. Some people got redeployed voluntarily because they wanted to do the work, and some were forced to got redeployed. Policy changes around guidelines being constantly changing. Every day there's a new guideline about screening and testing and all of those things. Public health measures being constantly changing that impacted their care process, but it also impacted their personal lives. And then personally, because of work conditions and everything, lack of sleep and rest, and the care responsibilities at home. These are some of the common concerns and triggers that's emerging from the research right now. So I'm going to move on to our panelists. We have 4 international experts here. So Dr. Larissa Thomas is from California. She is an MD and MPH. She has been doing research on physician burnout for several years. I will ask Larissa to introduce herself when I go into the questions. Dr. Robert Maunder is from Mount Sinai Hospital, and he's a psychiatrist, and he has been doing research around physician burnout and wellness. And in fact, he has a CIHR research right now looking at peer networks and burnout management. And Dr. Mamta Gautam is an internationally known speaker and researcher and psychiatrist, and she's also a coach, and she has been working in the area of physician burnout. So Dr. Gautam is here as well. And Emily Musing is the Vice President of Quality and Patient Safety, and who has been in the front lines and working with seeing the healthcare environment changing, but also looking at the physician and healthcare workers burnout from a QI and patient safety perspective. So welcome, panelists, and thank you for joining us. So we will move on to our questions. Dr. Gautam, from your experience, because you have been a coach, you have been a psychiatrist, and you're working in this area, what are you seeing right now? What are some of the emerging issues that you are observing?
Thank you very much, Abby. Really appreciated your summary to start. And I think that a lot of my comments and what I've seen certainly aligns very much with that. I had the privilege of speaking to thousands of colleagues across Canada right after the lockdown happened in March. I realized, as a psychiatrist, that there wasn't as much that I could do in the front lines in terms of working with COVID, but what I thought I could do is do what I do best, which is help my colleagues. And so I did set up a Zoom call every day, and some of what I'm going to tell you is really what I heard from colleagues during those, I guess it was 77 consecutive days that we did speak during that time. And the first thing I want to say is that I was really impressed at just how amazing and compassionate and caring physicians are. I know I always knew that, but certainly I think that came to the forefront as we started off in this pandemic. And people were very kind and caring about our patients, but also about each other. We went into this pandemic with a very high rate of burnout, studies saying up to 50% of physicians experiencing some of the symptoms of burnout, moral injury, a high rate of depression, probably the highest rate of suicide among any profession. And this is important, of course, because it's wellness in medicine is a quality indicator. And what we see is that physician mental health has been definitely exacerbated throughout this pandemic. Reports and some of the research as early as May was reinforcing the fact that we're seeing even increased rates of anxiety, depression, stress, burnout, insomnia, PTSD. Those are the kinds of things that we're seeing. What I see as I look back is that we progressed probably through about 4 stages. So the first stage was readiness. Really, there was this high degree of anxiety initially as we anticipated what might be ahead. We had looked at what our colleagues in Italy or even closer to home in New York City were experiencing, and we knew that that might be what was in store for us. And in fact, one of our colleagues in the US coined this pre-TSD, right? So it hadn't even happened yet, but that level of trauma was absolutely there. And what we saw were probably 2 different kinds, well, 2 main groups of colleagues: those who were working very hard in the front lines, feeling overwhelmed, feeling scared, and hoping they could, of course, do more, but feeling exhausted. And then there were physicians who were actually working less than they normally would. They were at home, hoping to free up our healthcare system for more urgent situations. They wanted to help, and what we saw there was a lot of sense of guilt and perhaps fear about, again, what might be ahead, and partly, as you mentioned, the fear of redeployment. What am I going to be asked to do, and will I be trained to do that, and will I be able to do it to the very best of my ability? And I would say at that, throughout all this, probably one of the biggest concerns was really the concern about, will we have adequate PPE? And, am I going to be able to protect myself and my family and my patients if I am at risk of exposure? We moved into the second stage, where now we're in the middle of it, and this is the response stage. We're starting to see some issues closer to home, and some of what I saw our colleagues talk about then was, again, the sense of guilt about feeling like they weren't doing enough, and the sense of loss, the loss of control, the loss of certainty, the loss of our day-to-day life, and a high level of grieving as a result of that, and lots of stories coming out of compassion and kindness within healthcare workers. We started to see the additional stress from people working from home. We talked about the increased burden. So certainly, if you're trying to homeschool and you're trying to take care of elderly relatives, or if you're single and alone and fairly lonely, and starting to see that it's, even though we're at home, the issue about self-care is harder to do. The next stage, the third stage, as I look back, I call it sort of that reassurance or relief, right? It wasn't as bad as we thought, luckily, here in Canada and in Ontario, and we were able to keep it under control, and a little bit of what I see, or I call unrequited anxiety, right? So we had the anxiety, didn't quite happen, and really hard to maintain those high levels of adrenaline and intensity that we had, and just a sense of letdown and perhaps inadequacy at that point, and exhaustion. I'm not going to be able to keep this up. We did start to see colleagues talk about PTSD, particularly those who were redeployed, and here in Ontario and also in Quebec to long-term care centers, and some of what they saw there that was really quite difficult. And then that was followed by the recovery, the reentry. Things are a little bit quieter, and people are really looking now at reintegrating back to work. Again, the concept of PPE, and do we have enough as we go back into our offices and see patients face to face comes up again. And what's very interesting then, I noticed, was that while physicians were inherently compassionate and caring, started to see an increased level of frustration and increased conflict. And I think that some of this was because, even though there was perhaps some indication that medically we were safe to re-enter, there's a big difference between it being medically safe and it being psychologically safe, right? And I think that even though we were told we could, not everyone was ready to go back at the same time, which often did lead to conflict. And I also just wanted to speak about, since we are focusing on our female colleagues, that, you know, there was this idea that we were all in this together. And absolutely, this was not an equal opportunity pandemic. I really saw that female healthcare workers, like 70 to 80% of frontline healthcare workers are women, and they were disproportionately bearing the brunt of this, often with very distinct challenges and burdens. We look at disproportionate job and wage losses, the excess responsibility in terms of caregiving and housekeeping and taking care of the children, schooling, and those of us in academic medicine, as a result, being able to be, you know, academically less productive, you know, which is very distinct from our male colleagues. So I'll just wrap up there and look forward to hearing from the other panelists. Thank you.
Thanks, Dr. Gautam. Dr. Thomas, I know you have been working on physician burnout even before COVID-19, but you have seen the trends happening in the US, and especially in your role as the Director of Wellbeing for graduate medical trainees. Are you seeing similar concerns from medical trainees' perspective? And what are some of their main concerns?
Thank you. Thanks for having me. Yeah, I'm the Director of Wellbeing for Graduate Medical Education at UCSF, and I also direct a national network of people who have leadership roles in graduate medical education wellbeing in the US. So I really echo a lot of the statements about the stress of COVID on frontline providers. I think certainly we're seeing that in the US. I think just to amplify in general, in the US, as you're all aware, there's a lot of turmoil and concerns about the way the pandemic has been managed at a national level, and that has compounded the overall healthcare worker stress. Not only the fear of adequate PPE, but the fear that those concerns aren't being heard, or that there isn't being adequate attention paid to the seriousness of the pandemic. I think that has been a real challenge, and I think the sense of betrayal that many healthcare workers have felt has, you know, at least at the beginning of the pandemic, certainly led a lot of people to consider whether a career in medicine or healthcare is something that they want to continue. So that obviously has tremendous healthcare workforce implications beyond any illness that healthcare workers may experience. I think specific to, and I also really resonate with the comment about loss. I think in my conversations with trainees, very few people have come to terms yet with the depth of loss that they're experiencing. And I think people have gotten used to such a high level of chronic stress that things feel normal, but they're actually, the baseline stress is so high that people are exhausted all the time, even though in San Francisco, we're lucky to have pretty low rates of COVID and infection. So I think for self-care strategies, trying to remind people that self-compassion is really important here, and that we're experiencing a generational trauma is one of the things I keep reminding people. It's hard to realize that when things have started to adjust to a baseline that is so far from normal. For trainees in particular, some of the things that we're experiencing that I imagine may be true in Canada as well, but I would love to hear other comments from the audience with other panelists, are with our match system, transition to new cities. So both transition out of residency and fellowship without any type of ritual or ceremony marking that, concerns about job prospects and moving to new cities, and then also the transition into residency or fellowship, moving from a new city. I think the isolation that was highlighted earlier is certainly true, but I think that it's compounded by the isolation of moving to a completely new city with no social contacts. In most of our residency programs, the social connection of the residents to each other is the most protective factor against burnout and mental health challenges. It's one of the strengths that tends to be that tends to exist, the peer support, and I think we've really lost that, and that's been very detrimental to well-being. And then one other interesting concern that we've heard increasingly as the pandemic has progressed, and we continue to have limitations on in-person gatherings and various restrictions on in-person care, are concerns particularly from procedural specialties about impact on training and the ability to get the number of procedures to become competent enough to independently practice. It's less of a concern, I think, for non-procedural specialties or the cognitive specialties, but we're certainly seeing a lot of concerns about that. And while the medical boards in the US are the accreditation boards and the professional societies are trying to be as flexible as possible, there becomes a reality of truly feeling competent to be able to perform surgical procedures in the time frame of residency when the number of procedures is curtailed. So those are some of the things that we're seeing, and I would love to hear how that resonates in Canada as well.
Thanks, Dr. Thomas. Dr. Maunder, from your, sorry, actually I'm going to go to Emily Musing and then come to Dr. Maunder, because the discussions we had about patient care is also key. From your role as a VP of Quality and Safety, are you concerned about what you're seeing with the pandemic and workforce stress and burnout? And if so, what are you seeing from the front lines?
So first of all, thank you very much for inviting me to be part of this panel. It's really a pleasure. I would say that there's a Chinese proverb that says, may you live in interesting times, which is a curse actually. And I have to say we're living in very unprecedented interesting times as we speak. And really I bring from my perspectives what I'm seeing from a staff burnout perspective, as well as how this whole COVID situation is impacting patient safety. So healthcare workers, I would say, are in especially stressful positions right now because they certainly are faced with the same levels of anxiety and fear that the general public have with regards to the unknown and the changing nature of this pandemic. And certainly it took some time for us to learn even the basics of, what is this coronavirus and, how is it transmitted? What can we do to prevent it, and what's the treatment should someone get it? Then on top of that, healthcare workers are really placed in positions where they feel a sense of responsibility to actively support their families and friends who may expect them to know always what the latest information is with regards to the pandemic, or may rely on them to have to care for them should families and friends develop symptoms or become ill with the virus. And this especially, I would say, applies to female healthcare workers who are traditionally have assumed the role of caregivers, both for their parents as well as for their children. So over and above this, at the same time, healthcare workers are always told that they are essential workers. So they're expected to get to work and be there for their patients, regardless of their home situation and personal anxieties. And then while they're at work, clinicians have a feeling of burden of responsibility for having to do things like tell patients that they have to delay their own care if it's non-COVID because we're simply running out of supplies, medication, ventilators, etc. Or to tell families of those patients that no, you can't come into the hospital because we're trying to decrease our visitors and the number of people that are coming on site. While at the same time, often healthcare workers within the organization have to learn a whole new set of rules on how to keep themselves and their patients safe. So all of this certainly has led to an extreme high level of anxiety. I've seen it, and the level of stress, both within our healthcare leaders as well as our workers. And then also from a safety perspective, I would say there's always an increased risk when you're making decisions in response to constantly changing information and knowledge, which we certainly had to do in this case, such as even which staff need to wear which types of masks. Or when you're implementing procedural changes without necessarily having the time to pilot things and to test for unintentional consequences. So a good example here is we had to move all of our IV pumps outside of patients' rooms to try to avoid contamination, especially if they were suspected of having COVID. But this led to a whole different series of workflows with regards to how to change the pump lines, how to ensure that they were running correctly. And finally, the need for training and redeployment of staff to new areas, whether this could be procedural skills they need to learn to work in intensive care, or could be they were redeployed to be door screeners or contact tracers, or even to work outside of our hospitals. Several of our staff were asked to work in long-term care homes, which was an environment they were not used to. So when we look at our incident debriefs on the issues that occurred during the pandemic, there were some common contributing factors to these issues. It had to do with suboptimal communication supports. For example, we realized quickly that not everyone in our organization had email access or were able to use their emails to find out what was going on. Also, lack of clear policies with regards to newly implemented processes, such as who and when to wear what types of masks. Insufficient staffing numbers or availability of trained staff for specific areas and job duties, such as the sudden increase in need for housekeeping, health, IPAC, infection prevention and control. And finally, difficulty in prioritizing how to distribute the limited supplies and resources, such as hand sanitizers or ventilators or pharmacy reports to me. So I'm very aware of the fact that we had a lot of our paralytic medications, which are usually used for OR, but we needed to divert it for use for COVID patients, which then impacted our ability to carry out our regular volumes of surgeries. So certainly COVID has challenged hospitals, and I would say healthcare workers certainly, to continually change our workflows and our processes in order to be able to help our patients while keeping both our staff and our patients safe. Thank you.
Thank you. That's really interesting about the technology and the emails. Like, not everyone has access to emails, right? We always think, okay, let's send an email and let everyone know, but not everyone in the, that's like really interesting. Thank you, Emily. Dr. Maunder, I know you have been working on this area for a long time, and you have some research done around SARS time, and now you're working on peer support networks to improve burnout in hospital workers. Tell us more about your research and what are some of the emerging themes that you're seeing from that work.
Sure, thanks for the opportunity to do that. I'll distinguish a little bit from what we've been doing kind of in the hospital on the ground, just to support our colleagues, and how that's being operationalized in a research project, because they're quite connected with each other. But we've actually we were at work trying to provide peer support starting in about early March, and the research is just kind of catching up to that as we go. So we're we have the advantage, I guess, at this point of having been through SARS and learned from the experience of the impact of that stress on healthcare workers, and how we were trying to apply that to some of the preparations prior in preparing for flu pandemic a decade or so ago. Coming into this pandemic, we kind of thought that we knew what we were doing, that we'd learned some things about how to promote resilience and help our colleagues. And at the same time, we'll trade old quotations here about this. So Emily was talking about living in interesting times. I remember that the line that generals are always preparing for the previous war. So we felt prepared, and we've been able to apply some of that knowledge from previous experiences. But this pandemic is completely unlike anything that we've been through before. So once again, we find ourselves in the position of kind of making up things as we go and trying to adapt to circumstances. So starting in the spring, we developed a program that we ended up calling coaching. So we have about a dozen psychiatrists, social worker, bioethicists who call ourselves coaches, so that we can provide some kind of support to our colleagues in other areas of the hospital. And we've settled on the word coaches because we want to kind of be clear that we're not acting as mental health professionals. They're not our patients. We are dealing with peers, but we are peers with some expertise. And so what we do is as individuals, we link ourselves up to different parts of the hospital, wherever they perceive a need, wherever they invite us to go. We will one of our coaches will kind of become their coach. And what we do is quite different because it's adapted to the needs of places. So it's, that's in person, attending huddles, attending in-services in some places. It's going on Zoom meetings in some places. It's a little bit of training. It's a lot of listening. But we've been providing this sort of support to really diverse areas of our hospital organization for several months now, right? So some of it's quite acute, so ICU, emergency, coaches in the long-term care homes that we were working in, and some of it in very different circumstances, right? So the people have been kind of talking about the difference and sometimes the tension between people who are kind of working at the front line and those who are working from home or having to work from home. I heard one person refer to frontliners and sideliners at one point, and the kind of dynamics and tensions that being in those different areas raise. So coaching is kind of different as it's distributed in different areas of the hospital, and then it's been very different in phases, as Matt was talking about, kind of as we moved from anticipation to being right in the thick of it, to being tired but relieved that there was a break, and now this kind of dreadful sense of, oh, here we go again, which kind of guides the sort of assistance that we've been providing. So it's, what we do is a little bit educational, but it's not very educational. Mostly we listen, we help people kind of surface feelings. Sometimes there's a little bit of problem solving. Sometimes we can kind of serve as a liaison between frontline people and senior management. So there's a bit of advocacy involved in the work sometimes. An opportunity for people to speak for sure, but sometimes to kind of formulate their communication a little bit clearly, because we know how poor communication in the midst of something that feels like a crisis makes things so much worse. So that's been going on for several months. And with this research project now, we have the opportunity to operationalize that, to formalize that. So we're hiring peer resilience champions, we're calling them, to do the similar sorts of work in the hospital, but we'll do it in a way that's follows a research design so that we actually have the capacity to evaluate the impact that has, so that we can, because first and foremost, we want to try and do some good, but we'd also like to generate some evidence to know whether the things that we think are doing good are actually helping or not. So we're rolling that out over the next 18 months or so. And unfortunately, the pandemic seems to be cooperating and providing stress-causing material for us to deal with over that extended period of time. So we'll see a couple of years from now how well we've been able to do.
Thank you. I mean, that's key, like to understand what's going to work in what context, because I think responses to burnout is like not one size fits all. What works in one hospital, one context may not work in the other hospitals. The problem is we don't have a lot of evidence-based information on what interventions work for what context. And we need more research around this. And I'm seeing a couple of questions coming through, and that actually the question is similar to what I was going to ask you, because we know the problems. We are seeing these things. We have about 6 months of experience now, but we are also seeing a trend of a second wave coming. What should we do? Like, what should the systems do? How can the hospitals and the managers, the leadership, manage the burnout concerns of their healthcare workers? I'll start with Dr. Gautam.
Thank you very much, Abi. I think, absolutely it would be essential for us to have learned from what we've been experiencing as we move forward. I cannot stress enough, right, the importance of leadership in ensuring wellness of the people that they lead. And, there's more and more written now about the concept of compassionate leadership. And I think that's really what we need to see showing up at this point. We need to have leaders who recognize that there has been an emotional cost for the healthcare workers here. There's a need for restoration and continued support. And I know that you know, there has been some work on looking at, you know, what do physicians need from their leaders, and you know, we need leaders that are going to listen to the people, to actually understand and acknowledge what they're going through. Dr. Thomas spoke about in the U.S. context feeling like, you know, things are being dismissed and feeling betrayed. So we need to feel like it's not being dismissed, right? That we're actually understanding and we're supporting our healthcare workers and recognizing them and honoring the work and the sacrifices they've made. I also just wanted to mention, you know, as I said, PPE has been a concern throughout this whole thing. And so here we go again, as we look ahead, I think that we need to look at, you know, how can leaders now, knowing this, ensure that healthcare workers have the physical, you know, PPE that they do need. Very interesting work coming out of IHI, the Institute of Healthcare Improvement, and they're talking about psychological PPE. And the reality is, right, you know, we've been called heroes on the front lines and even on the sidelines, but the heroes are hurting, and heroes really don't reach out for help easily. And so I think one of the things that we need to look at from our leadership is really just, you know, having some of these supports be like PPE, which really effectively is, you know, a simple, automatic, ritualistic thing. It's like donning and doffing. It's just what we do. And so some of the psychological supports have to be, again, just what we do, right? And to have them normalized and accessible in that way. So I would really encourage leaders to start looking at that, looking at some of what we know helps resilience in healthcare workers, and then, you know, creating an environment and creating access and giving people, you know, not just that opportunity, but the time and the support to take advantage of those opportunities.
Okay, thank you, Dr. Gautam. Dr. Thomas?
Yeah, I echo all the comments about psychological first aid and including that in planning for the second wave. I do want to highlight a few positive aspects of the second wave coming. As a clinician, we have learned so much about how to care for patients with COVID. It does seem that even in older patients, the mortality is going down. And we have really good evidence now that PPE works. There was actually concern before that it didn't work, but we do know, assuming that we have adequate PPE, it's very effective. And I think not also facing a disease unknown will take away a lot of that cognitive stress that really overwhelmed people, in addition to the moral distress of the first wave. So I think those are positive aspects. I think also knowing strategies for physical distancing and other non-pharmaceutical interventions that are effective in regions that are willing to deploy them will be very helpful too in keeping the health systems from becoming overwhelmed. And so I do feel positive about that in terms of the medical preparedness, but I think that the moral distress of people dying in relative isolation and just the compassion fatigue and cumulative stress of seeing a disease that has such a high human toll will remain, of course. And I think that I very much echo the effort to inreach and proactively acknowledge to people that they need support. And I think it's great to have resources available, but I think in terms of leadership, also normalizing that, and to whatever extent leaders can actually speak to their own experiences. I actually just personally came back from maternity leave into the height of the pandemic. And so I think just acknowledging, you know, how world rocking these things are for us. I saw someone ask in the chat, you know, what are the particular effects on women? And we know that women are a higher percentage of essential workers in general within and outside of healthcare, and also that women obviously in most cultures bear a disproportionate load of caregiving, both for elderly relatives and for children. And I think that the pandemic has only amplified these types of societal disparities, and in areas where the social safety nets, speak to the US, are less robust. I think that this is further exacerbating these types of situations, and we know that it's affecting women's opportunities for job advancement. We know that women are likely to get behind in promotion or opportunities for job advancement too. So I think that all of these things will be taken into account in the future.
Thank you, Dr. Thomas. Emily?
So maybe I can share some of the things that the University Health Network tried to do to support resiliency and well-being. I think one thing we realized early on was one of the greatest sources of stress for our leaders and staff was just a lack of information. So certainly our CEO had lots of virtual open forums where people were able to ask specific questions and get answers from him directly. But one of the other things that happened was several years back, our organization went through a patient safety journey where we created daily patient safety huddles that happen in every department, every unit. Usually it's 10-15 minutes in the morning, everyone gets together. These turned out to be great sources to allow our staff and leaders to talk every day, to share new information as it happened, but also for staff to share and escalate newly identified risks or concerns that they may have. So that was certainly one thing that was really important to in helping our staff with their stress. The other thing is to be able to function in a stressful environment, staff really need to feel safe. So first of all, for any of our staff who could work remotely, certainly we allowed them to do so that it avoided their exposure both within the hospital, but also just during their travels to and from work. And I don't think this is going to change in the near future. Staff who are able to work remotely are likely going to continue to do so for the next little while at least. Also for staff on site that need to be on site, we had to relook at all the physical spaces and workflow redesigned to allow for physical distancing. This is not an easy task because many of our workspaces just were not built to allow for that amount of physical distancing for staff. So a lot of thought had to go into that. And obviously not all non-essential meetings were canceled. Those that were required were turned into virtual meetings. So we're very used to now using Teams, Zoom, etc. And a lot of our staff had to be redeployed. So the other thing to make them safe was to just give them sufficient training so that they could even feel confident and supported in carrying out their new duties. The third thing I would say is don't underestimate your own staff and team in their ability to find ways to also build their own resiliency. We had a lot of individuals who reached out to others. One person had links to the National Ballet, was able to connect with them online and bring this online in their areas where they could do socially distanced stretching exercises, and there was yoga going on. So a lot of times it was really allowing those individuals and making them realize that, you know, that was something that was valued within our organization, and we wanted to help them do it in a safe way. And certainly with the help of our donors, we did little things like, you know, provided people with meal vouchers so that hopefully they had easy access to food, free parking, etc., just to make their lives a little bit easier. And I would say the other thing is it's really important to provide staff with acknowledgement and a chance to celebrate during times of stress. So our team certainly celebrated each time a ventilated COVID patient was able to go home, or we encouraged our staff to participate in other celebrations, such as there was a parade of Canada Post trucks, which came across a University Avenue. We want to ensure that our staff were able to see that and participate in it. So they recognize that people outside of the organization really valued their service. And then we recently hosted an innovative summer appreciation event for our staff where we gave them vouchers and there were ice cream carts located outside our entrances. I think anytime there's times of stress, you need to still keep that feeling of celebration, acknowledgement, and a little sense of fun as well. And I would say finally, as we're returning to our previous clinical volumes, while watching out for a second wave, it's equally important to sustain many of these things, these changes which we've put into place so that staff can continue to build and maintain their resiliency. Because I would say, getting through this pandemic is really much less like a sprint and much more like a marathon. It's going to take a little while. We need to hang in there. We need to pace ourselves.
Thank you. And Dr. Maunder, I'm actually going to ask you specifically about your peer support group because there's a lot of interesting questions coming around about that. Have you seen any differences in terms of utilization between female health workers and male health workers? Do you see there's any gender differences in terms of uptake and engagement in this?
Yeah, it's a hard question to answer. I mean, I need to answer experientially, right? Because we don't have it's not a I don't have a research response to that from what we've done so far. It's complex because there are great differences between what we see in different disciplines and in different areas of the hospital, and the distribution of people in those disciplines and areas is quite gendered, right? When I do coaching on a surgical nursing unit during the nurses' break, the majority of the nurses are women. And if so, I'm thinking back to a time where we were doing this in August, where there weren't a lot of COVID cases. There might have been none, so that kind of acute risk-focused, PPE-focused kind of concern was less at that point. The entire discussion was about having 2 full-time jobs, right? About trying to work all day and then go home and manage the expectations of the family, and you know, either dealing with online school, which is late in the last school year, or preparing for the who knows what of going back to school this fall. And so it was you know, it was entirely focused on this kind of double tension of trying to be a professional and trying to manage all those kinds of concerns at home as well. And it was a discussion almost entirely with female staff, which is completely different than when we're talking, trying to connect with the anesthetists or surgeons or whatever, where that's not entirely male, but the distribution is quite different. And there, all of our effort is just to get people engaged and get people to come. It's so hard to get people in those sorts of positions to have any kind of discussion that threatens to reveal a feeling. So there's these great discrepancies, but I don't feel like I don't feel like I'm on firm ground knowing what to attribute to differences in kind of gendered experience and what to attribute in other kinds of differences. I feel like that's kind of not my call.
Yeah, no, thank you. That's very helpful. And the things that you talked about from Emily, you know, the initiatives that UHN is doing, your CEO reaching out to all staff every day with information, to Mamta talking about compassion-focused leadership, and Larissa talking about all the changes that we need to do in terms of from a graduate programs to like the concerns that new graduates are thinking about whether choosing medicine is the right thing, right? This needs really a culture change in terms of how healthcare is viewed, and especially for female healthcare workers, we need a system that's going to be supporting them so they could manage. And Robert, you talked about the double job, the 2 jobs. They have job at work and then they have job at home. Like, how are we going to do that systems change and culture change? What do we need to do for that? I know it's not an easy answer, but from your experiences, what do you think we need to do to inform the systems for a culture change, to have more compassion for female healthcare workers? Anyone?
Well, I'll start that because I think it's not certainly not the, I don't, you know, obviously none of us have the answer, but I think one part of the answer is just some of the work that I am very excited to be involved in, which is really about leadership development for women in medicine. And I see that, you know, as you know, and not just having more women as leaders, although I think that they will bring this knowledge, this experience, the need for understanding and being perhaps more thoughtful and compassionate to the women that they're leading and understanding what their lives are, but also just having the ability to have our male colleagues who support women leaders in medicine as well be, just having more of those conversations and understanding, and the fact that we're talking about that today and being able to highlight that this is what we saw, I think is going to make a difference as we move forward, right? But I do see that, certainly areas where we do have women leaders, these are the kinds of things that are spoken about perhaps a little bit sooner, a little bit more openly, a little bit more easily. And to Emily's point about allowing your team to come up with the solution, as there are women leaders and more women on the team, we start to see some problem solving happening in that regard. So my hope is that that will continue.
So we need more female leaders in healthcare to make these changes happen. Thank you. Right. Yes. Robert, your thoughts?
My computer is trying to keep me quiet on this point. No, I agree with that completely. I was thinking, I hope I'm not on a tangent here, but I was thinking back to, we were talking about how to protect against burnout. And I think these are related in a way, right? That the, so much of the kind of reflex effort to do something to build resilience and to reduce burnout gets focused on individuals. I haven't heard that from anybody in this group. I think, but it's quite typical of discussions that I have with my organization, that everybody's first thought about improving resilience and reducing burnout is we can provide yoga, we can provide stress exercises, we can link people to EAP. It's all individually focused. Whereas like most of the drivers of burnout that are really persistent and difficult to control are systemic, right? So in non-COVID times, it's the weight of documentation and the long hours and the lack of control over your schedule and EMRs and all that kind of stuff that are burnout. So individual fixes to systemic problems are kind of wrong-headed, right? This is not going to lead to a clear conclusion because you're watching me think as I go. But the more systemic approaches to that are to focus on leadership. So more women as leaders helps to change that dynamic. Focus on communication, like clarity of communication and honesty about the uncertainty in the situation and all of the gaps in our knowledge moving forward, help people with resilience. And we like to talk about focusing on reserves, right? And maintaining your reserves, which to large organizations usually means like money and stuff, right? So reserves of PPE and reserves of drugs and stuff like that. But it's just as important to focus on relational reserves, that we have to actually like build effective working relationships into our organizations, because that's what we fall back on and that maintain our resilience during difficult times like this. And if I was more clever than I am, I would link that to your question about gender at the end, but it feels like it's an important part of the matrix to me.
Thank you. That's beautiful. Larissa?
Yeah, I think just to echo the point about system solutions, I think culture change can be driven from the ground up, and also policies and changes in structures are needed to allow culture change to happen on a large level. One of the interesting things in the US at least is that a lot of funding appropriation and adjustment to regulations have occurred in the setting of COVID. And I think that both within individual healthcare institutions as well as nationally, this really presents an opportunity to try to right size some of the structures that have always disadvantaged women in the workforce. Specifically, I will speak only to the point of view of working in the US because it's the only point of view I can personally speak to, but the flexibility for telework, I think my own institution is planning to adopt that ongoing, and allow people who don't truly need to be in the office to develop telework plans for partial telework in the week, which especially in cities where commuting and things like that are really challenging, can provide more flexibility to those who have the ability to do some of their work remotely at least 1 or 2 days a week. Similarly, I think for clinicians, particularly primary care providers, the ability to get reimbursed for and to have telehealth visits count as real visits is hopefully something that will persist after this, which allows can be less burdensome in caring for certain patient populations. And then finally, we've received a lot of funding to enhance childcare support related to COVID. And my hope would be that my own institution will advocate for this to become more of an ongoing recognition that this is a must do, not a nice to have, that everyone needs comprehensive childcare, and how important that is, not only for essential workers, but for anyone who is trying to work. And then finally, in the US, we have a major culture of overwork, particularly in medicine. And I think that the true limit, like the extreme limits people have faced on the amount that they're able to physically do their jobs while trying to also school their children, again, has highlighted that no one should have been working so many hours in a week in the first place. And so hopefully some of that, although for very bad reasons, this has changed, there are potentials to channel this into some lasting ways and changes in the ways we do work.
Best thing, we need to change the way we do work, and we need to change the way the current culture of healthcare works, because it's not going to be sustaining. Emily, any other comments?
So I would say that I think that the very fact that we're even having this panel discussion, that we're talking about burnout and specifically the stress linked to females who are working as healthcare workers, is certainly an indication that we're taking a step in the right direction. The fact that it is discussed in undergrad and postgrad courses and also acknowledged within the workplace, I think is all to the good. I mean, for me, because I work so much in patient safety, I always link it to some of the things that we're doing there. And when I think about what we initially tried to do with patient safety, we focused on specific processes. We wanted to decrease falls or pressure injuries. But now we're coming to the realization that it's even more important to look at systemic issues that impact culture. So for example, in patient safety, we're looking at things like, what is it that's causing a problem with regards to transfer of information and the way we communicate with each other? Or what are the things which make people feel unsafe to escalate their concerns? All these things can apply as well to how do we make our staff and healthcare workers feel resilient at work and feel supported at work. How do we communicate with each other so there's open communication and people have the information they need to do the work that they need to do? And also, when they have a concern, how safe do they feel in escalating that, regardless of the fact that it could be 3 in the morning that they have a concern about a patient or themselves or something within the environment? Do they feel safe to actually call on whoever they report to, or the unit manager, or the person that's in charge of the trainees in that area, to express that? And what is the response that they get when they actually express that concern? I think that's the bottom line in ensuring that we have a culture that supports our trainees and our workers.
Thank you. That's so powerful. And I know some of the questions were also focused on the need to listen to the healthcare workers instead of like a top-down intervention to say, okay, this is what I heard somewhere else at work and I'm going to do it in my hospital. Really understand it from the healthcare workers' perspective to say, what do they want? Why do they want? And then to implement that intervention to support them is so okay. So thank you for your time, panelists, and sharing the importance of burnout and addressing that through culture and systems changes. And we will continue to have this dialogue, and thank you everyone for your participation. And please feel free to reach out by email and we'll be able to send you additional information. So I will conclude and end the session now. Thank you.
Thank you.
Thank you. Thank you for involving us.